Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Hello, we're here at the San Antonio Breast Cancer Summit 2023, and I'm here with my friend Dan Lenahan, who's often co-hosting these podcasts, and we're here today with Icro Meattini. I hope I said that correctly, but we're glad to hear from you about your experiences and some of the things that have been going on at the meeting here. So thanks for taking some time.
No, thank you very much. Yes, I'm Icro Meattini, perfect pronunciation, and I work as associate professor at the University of Florence, Italy, as a clinical oncologist, mainly focused on breast cancer, but not exclusively breast cancer care. Basically, I'm mainly involved in de-escalation optimization studies on radiation oncology, so optimization of strategy with breast, partial breast irradiation, and escalation strategy at all, but also cardiotoxicity impacts of cancer-related treatments, systemic therapy for breast cancer, locoregional advance, and some trials in the escalation. So basically, these are my focus, especially focus on the integration between systemic therapy and radiotherapy. That is something really important in this era of cancer care.
So Icro, this is obviously a very important meeting, and a large population of providers from all over the world come here to talk about the latest advances in breast cancer treatment. Have there been anything presented this time or recently that specifically about radiation therapy and how it's improved in the treatment of breast cancer?
So yeah, this is really a super meeting because of the multi-professional context. We are medical oncologists, surgical oncologists, cardio-oncologists, radiation oncologists. It's one of the last important meeting, real multidisciplinary, I think, on breast cancer. This year I was involved in educational, very nice. This was about patient-friendly partial breast and whole breast. This is for a very nice title because it was patient-centered, so the patient-centered perspective. So I had the chance to talk about all the optimization strategy, also to reduce the impact of toxicity of radiation therapy in breast cancer. Just take the chance that now most of patients can be treated just with 5 fraction in the early setting of radiation therapy. That is something completely different as you compare with the historical 5 to 7 weeks of adjuvant radiotherapy. This impacted a lot in the quality of life of our patients, reduce the time and improve the quality of life of our patients. We also talk about the chance to reduce volume and total dose of treatment. These, of course, have a significant impact in terms of also some adverse events. So, for example, the dose received by the heart and the cardiac substructures in our patients. So there is an important implications in terms of the current idea of potential cardiotoxicity related to radiation therapy. It's over the last decades, the context and the fear about radiation therapy on cardiac toxicity completely I feel completely changed. It's still very important, but we have to give the right priority now. And concerning the presentations, it was really an amazing presentations. You know that been published 1 month ago the BCTCG meta-analysis of regional node irradiation in breast cancer that basically find a significant impact in terms of survival, also to giving regional node irradiation even in not negative breast cancer patients. So this has some important implications and will increase the use of regional node irradiation for our patients even in an early setting. This also have implication on the total dose, because you know when you perform regional node irradiation, maybe including also internal mammary node in the volume, although you follow the guidelines, the contouring delineation guidelines, and you reduce the volume treated, but the dose to the heart will increase. So this is a very first important point to discuss in a multidisciplinary way. And here I've been presented at least one trial very important that test the significant impact of regional node irradiation after neoadjuvant chemotherapy. That show that there's not an impact in patients that have a complete response in the XIL after neoadjuvant radiotherapy and randomized to receive regional node irradiation. No, this was a really important trial that will probably lead to a reduction of regional node irradiation in this specific setting of patients. Although we have to be aware that the median follow-up of presentation data is still limited, and the multidisciplinary discussion is always the key. So this is just to put on the table some insights of the meeting.
So basically, the part about practice that would change from that particular study would be if you get neoadjuvant chemo and you have a complete response, that radiation wouldn't necessarily be needed. Is that
exactly that the point? The results of the study that it's completely different if you compare with the current guidelines, since a clinical node positive patient that receive a neoadjuvant chemotherapy for most of radiation oncologists is already an indication for a postoperative regional node irradiation. It was very nice discussion after the presentation of the trial, because one of the BCTCG meta-analysis authors ask a question, say that you are aware that we published now also the node-negative patient needs regional node irradiation. How this impact on the current practice on Monday. So the discussion is really open.
Super. And then is it routine, or like at this point, do all places that provide radiation therapy for breast cancer, do they do the deep inspiration breath hold?
This is a very important point. Now we have got at least 3-4 tools that will help us to reduce the dose to the heart and the heart substructure, critical substructure. Deep inspiration is one of the most important tools that we have in our hands. Unfortunately, the use is extremely heterogeneous across country, across cities, local policies, and it's strictly related to also, unfortunately, to resources of country of the country and the city. But
I guess that's one of those things I don't understand. Why would that be a limited resource? I mean, that's just it's a more or less a mental thing. It's not. It's a tactic.
There's everything that led to a change. Have some implications in terms of background expertise, learning curves, time saving, and so if you only think that to improve the use of hypofractionation lasts something 15 years when a level 1 evidence was already on the table, even level 1 evidence needs time to be incorporated in our current practice. Anyway, from a scientific point of view, I think the deep inspiration breath hold is something that we should routinely use, at least for the left-sided breast cancer, but not exclusively, because you know very well that for example, the addition of regional node irradiation, even on the right side, leads to an increase of heart dose. So it's something that we have to evaluate. Radiation oncologists should evaluate the plan, even in free briefing, and deep inspiration breath hold, and always favor the most favorable plan, regardless of the side.
Yeah. So I'm probably going to reveal my ignorance about radiation therapy, but for example, the treatment of lung cancer with radiation, they frequently do SBRT. And I'm not sure I know what all the letters stand for, but they'll do SBRT, and the basic point is that they really focus their treatment to as small possible areas as you can do. And of course, for lung cancer, the heart is in the middle of the field for the most part. So does SBRT play a role in breast cancer?
Unfortunately, currently SBRT has no role in the routine practice in breast, because yes, it's the key treatment for lung cancer, able to deliver a higher dose in a very small volume, reducing the dose to the organs at risk around. But in the breast cancer setting, where currently is the postoperative setting, the most important setting, you still have to treat the whole breast or the partial breast following the recommendations, but you have not the tumor there. So that's why we are investigating on the role of preoperative radiation therapy for breast cancer. In that case, stereotactic body radiotherapy can play an important role, because you have the target there, you can reduce the volume and can use the radiation therapy as a focal treatment with the tumor there. But this is still investigation, because preoperative radiotherapy is not standard of care, but there is a lot of experience of different ablative radiation treatment in this setting. This could be one future option, I think.
And then is proton therapy an option? I know that's a limited resource.
Yeah, it's not something about limited resource. I think the proton therapy is standard of care for specific tumor sites. Because of the radiobiology of proton therapy is able really to give always a winner plan for specific tumor site. Breast cancer is not basically the primary disease for proton therapy, but there are several ongoing trials, and I am also involved in one of that as external reviewer, and we really need important high quality data, control data, to demonstrate who's the patient that should receive even proton therapy in the setting of breast cancer patients. So selection of patient, basically, yes, always is the key.
Well, this is really interesting. And what would you take away from this meeting? Was there something in particular that you think you learned, or was your thinking was revised based on what you listened to here in the meeting?
Yeah, I think that, again, as every year that I come here in San Antonio, despite the long journey traveling, and then we come back every year because of the multidisciplinary. This is the main side. This is the right place to networking with people from different professionals that share their perspective. And in the breast cancer care, this is really crucial. This is really the key. So you can follow the exercise trial during chemotherapy, and the concomitant radio systemic therapy publication, and the systemic therapy advances with the safety profile, the cardio-oncology relevance, all the same place. So we will come back again.
Yeah, well, you just kind of gave us our marching orders as far as I could tell. I mean, I think that in the world of cardio-oncology, it's all about multidisciplinary approach to the patient and whatever their treatment is. So I mean, that's like one of our highest, if not the highest priority, is we have our considerations from a cardiology point of view, but we want the patient to receive the best cancer treatment, whatever that is, and how to make things, get the heart out of the field in the case of radiation therapy, or how do you apply cardioprotective medications so that people can tolerate those treatments better. I mean, these are all major considerations. So yeah, this is obviously a very important meeting for people that are treating patients with breast cancer. So
if we all apply the potential strategies to cardioprotect our patients, from drug protection, pharmacological protection, the right technique, the right patient, the right selection of patient for reducing the burden of treatment, both systemic therapy. Think only about the use of anthracyclines, for example. There was here a nice presentation of the needs for anthracycline, for example, for breast cancer patients. If we do all the best of our knowledge in this practice, we really can reach the best for our patient, I think.
Yeah, no, absolutely. Yeah, well, thank you so much, and it's really great to meet you in person, and I look forward to, I'm sure we'll be back next year, but there may be some other time that we happen to meet in person. I'll look forward to that.
Thank you very much for this invitation. Thank you very much.
Awesome.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.